Good evening, Facebook viewers. Welcome to our TIF Talk summer series. My name is Karen Girth. I'm a Market Development Manager at Endogastric Solutions. Tonight, we have the pleasure of having Dr. Michel here to discuss TIF, Gerd, and answer all of your questions. Thank you so much for being here tonight, Dr. Michel.
Absolutely. Nice to be here.
Good. So please, viewers, post your questions. He is here to answer them. I want to give you a little bit of background on Dr. Michel. He is a board-certified general surgeon. He has completed a fellowship in bariatric and minimally invasive surgery. He served in the U.S. Air Force early in his career as a pararescueman, very, very impressive. This experience motivated him to eventually become a general surgeon. He started performing bariatric surgery in 2008. He has extensive experience in all aspects of general surgery and has advanced training in minimally invasive esophageal surgery. His primary interests are anti-reflux, bariatric, and robotic surgery. Thank you so much for being here tonight, Dr. Michel.
Yeah, thank you for having me. I appreciate it.
So let's kick off our program. We're going to start again tonight with a new short segment, a little icebreaker that we call Fill in the Blank. So how it works is I'm going to prompt Dr. Michel with a question or a statement, and he's going to fill in the blank and let us know why he chose that word. Okay, so Dr. Michel, our first kind of statement is Gerd is blank.
Gerd is a disease.
And what made you choose the word disease?
Good question. So number one, the gastroesophageal reflux disease, it's in the acronym, but a lot of people I think don't recognize it as a medical disease, which it really is and has a lot of potential problems. A lot of people make sort of light of the symptoms of reflux, and what comes to mind is commercials out there that show the bacon or the pizza that are slapping you around, and if you take this medication, then you're better. And the reality is, for some people, it can be much more than that. So it truly is a disease, and we need to approach it that way.
That's a great answer. And we'll talk more about that, later on in the segment. But the next question is, leaving Gerd untreated is?
Dangerous.
Yes, that's the perfect word. And again, why did you choose that word?
Well, not to scare anybody, but GERD has the potential to lead to Barrett's esophagus, which can be a precursor to esophageal cancer. And I've seen far too many esophageal cancer patients to consider that just a benign finding and something that we don't need to pay attention to. It's because it truly can be dangerous. The reality is that happens in a very few minority of patients, but in those that it affects, it really changes their lives.
And then the last question, living with GERD is?
Miserable. Yeah, so for the vast majority of people, they don't turn into esophageal cancer. They don't get Barrett's esophagus. But for some people, it truly is miserable. I have a number of patients that tell me that they have to sleep in their recliner. They have to sleep upright. They can't lay down flat because the disease is truly miserable. For some people, it can affect them on a daily basis. It affects their sleep. It affects what they eat, how they eat. It affects their work because they don't sleep well. So it truly can be miserable.
That definitely would be miserable. And there's so many people suffering. That kind of leads us into, our next kind of questions and conversation. What's the difference between occasional acid reflux versus chronic reflux in GERD, and when should people be concerned and seek treatment?
Good question. What I think a lot of people don't realize is that acid reflux actually is normal. Most people should have a little bit of acid reflux here and there, but there's usually a reason for it. It may be a particular food, maybe you've overeaten or something along those lines, but a little bit of acid reflux that responds to over-the-counter antacids every once in a while, totally normal, nothing to worry about. But once you start to have symptoms on a more regular basis, if you find that you're requiring those over-the-counter antacids every day, or you're requiring a stronger medication on a more regular basis, then we've got a whole different story. On top of that, if you start to have other symptoms, trouble swallowing, if you're having episodes where the regurgitation actually leads to what's known as aspiration, you start coughing or choking, something along those lines, then again, we have a whole different story. If you have a large hiatal hernia, that may be another indication that we need to take the next step in your treatment.
Would those be considered the regurgitation? Are those considered more of the atypical symptoms versus just kind of the typical heartburn that people feel?
So most people do feel heartburn, and that is the most common primary symptom. They can be atypical depending on how extensive they are and how often they happen. But believe it or not, those are the things that I tend to see most often. Of course, I see patients whose disease is much more advanced than most folks. Yeah, and you can also get into more upper esophageal and oral pharynx type of symptoms as well. Those can be atypical, but are certainly associated with reflux, things like hoarseness, things like throat clearing, constantly doing that sort of a thing. So a lot of things that someone might otherwise attribute to something like asthma or some sort of lung disease or sinus problem, that may actually be a reflux problem.
Wow. So, if people are experiencing those types of symptoms, and do people need to minimize any activities, or is there anything that they can do to minimize those symptoms?
So not specific activities. In some cases, there are trigger foods that may be the source of your symptoms. And if you're okay with avoiding those trigger foods, and that's all you need to do, certainly that's a very simple solution. In some cases, it's not just what you're eating, but the amount that you eat, or perhaps how quickly you're eating. Sometimes eating too quickly or too much can lead to bloating, which then can lead to your symptoms. So if it's as simple as avoiding certain foods, that's a pretty straightforward thing. Typical trigger foods include citrus-based foods, tomato-based spaghetti, Italian foods for the most part, pizza, that kind of a thing. Peppermint, red wine, chocolate, those are typical trigger foods. But for some people, they can eat whatever they want and they still have symptoms. So avoiding foods for those may not necessarily be an option. But again, if it is as simple as just avoiding those trigger foods and you're okay with that, that's perfectly fine. As far as other activities, it's really difficult to avoid doing things that you need to do on a regular basis. If your job is to climb up and down stairs or bend over to pick up equipment, you can't very well stop doing those things just because you have symptoms.
So when you're seeing patients and you're kind of going through, their background and trying to see if they're a candidate for anything, what are the options that are available for treating GERD? What are some of the options that they have?
Sure. The first thing that we always start with is what we call diet modification and lifestyle modification. So again, back to the trigger foods. If there are certain foods you can avoid that are helpful, absolutely do that. Again, in some ways, changing the way that you eat, how you eat may be helpful. In a lot of cases, losing weight. What we do know that is that once you get to a certain weight, that pressure pushing up against your stomach can actually be one of the major causes of reflux. So something as simple as losing 10 pounds may really alleviate your symptoms. So that's where we start typically. If that's not working, then we start looking at medication options. And if medication isn't working, then we start looking at surgical options.
And what are some of those surgical options that are available?
There are 3 traditional fundoplications. There are some other things out there such as LINX, and then there's the TIF procedure. And then one thing that I will consider for some of my patients is actually a gastric bypass. Believe it or not, a gastric bypass is a very good anti-reflux operation. There are a few other endoscopic treatments such as STRETA, radiofrequency ablation. But I typically stick with the more, not so much the traditional fundoplications, but some of the other minimally invasive treatments.
brings us into the Tif procedure. Can you tell a little bit about the Tif procedure and how it works?
Sure. So the concept of the TIF procedure is to create a one-way valve at the bottom of the esophagus. So the whole idea here is that most patients that have reflux, it has to do directly with the lack of a competent valve at the bottom of the esophagus. So if that one-way valve is working well, then you shouldn't have reflux. But most people that have reflux, it's because the one-way valve isn't working. So the concept is to try and recreate that one-way valve or strengthen that one-way valve. And so what the TIF procedure does is an endoscopic procedure, which means you're asleep. The device goes through the mouth into the inside of the stomach, and the device is able to grasp the esophagus and the stomach and sort of pinch it together nearly 360 degrees around. And if you're able to see this, you can actually see that valve as it's being created.
Wonderful. So it looks like we have a lot of questions coming. So let's ask a couple questions and then we'll pick this back up. I do have one that is just really a statement. Patricia says that you operated on her in 2016 and you were the answer to her prayers. So that is amazing, and I'm glad that she's on watching tonight.
Thank you for saying that, Patricia. I appreciate that.
And so we do, we have a question from Wendy. Does GERD get worse with age?
Yes, it certainly can. Usually it does. GERD is also related to a hiatal hernia in most patients, and hiatal hernias typically don't get better on their own. If anything, they get worse. As a general rule, the bigger the hiatal hernia, the more likely you are to have worsening symptoms with your reflux.
We also have a question from Court. He wants to know, what can I expect as far as the process to see if I'm a candidate for the TIF procedure?
Sure, I do some typical testing depending on symptoms. First thing that we'll do is we'll have a conversation. So I'll sit down with the patient for about 30, 45 minutes or so, depending on what their symptoms are. We'll go through their symptoms. We'll talk about the types of testing that they may have had already. As a general rule, beyond that, I almost always do my own EGDs because I need to be able to see if the patient has a hiatal hernia or not. I want to see if there's damage to the esophagus. I'll do biopsies of the esophagus to look for damage from a different perspective. And more than often than not, I'll also do a pH study. So what we're doing is I do the wireless pH study, which is much more tolerable for patients. We put a small microchip in the bottom of the esophagus, and it literally measures acid levels over the course of the next 48 hours. So that is the gold standard. It's the best way to test for what we refer to as pathologic acid reflux. After that, I want to see the function of the esophagus. There's a couple different ways that we can do that. I'll typically do manometry with the majority of my patients, and I'll also get an esophagram, or what some people call an upper GI or a barium swallow. If there are any questions that somebody might have gastroparesis, often I'll get a gastric emptying study as well. And so all of those tests and information that we gather are what I refer to as the pieces of the puzzle. And once we gather those pieces of the puzzle, we can get a much better idea of the picture and what course of treatment we ought to pursue.
That kind of brings us into this next question. This person is asking, they have a small hiatal hernia and terrible silent reflux. Does TIF work for silent reflux? I'm lost here and I just need some advice.
Yeah, good question. So number one, there are a lot of different definitions of what silent reflux really is. So that's the first thing that we need to sort out. When somebody says silent reflux, what do they really mean? And so that's a great example of why I do a pH study. The whole idea of the pH study is I want to prove, again, pathologic acid reflux. I want to see if somebody truly has acid coming up into their esophagus and irritating, and is that the cause of their symptoms? And one of the reasons that I do that is I want to differentiate somebody that might be a surgical candidate from somebody that absolutely is not a surgical candidate. And so because the symptoms can be the same. Somebody may come in with heartburn or regurgitation and very typical symptoms. And if we do that pH study and we see that sure enough their acid levels are through the roof, that's somebody that typically does really well with surgery. And if on top of that we see what's known as correlation of symptoms, which is the other thing that the the pH study gives me, correlation of symptoms. If we see that, again, those people do very well with surgery. But in some cases, I'll see the exact opposite. I'll see somebody that records 100 symptoms and not one of those is associated with a reflux event, and their acid levels are completely normal. So if I were to operate on that patient, I would do them no good whatsoever. In fact, I would probably make their symptoms worse. So we need to really sort out what do you mean by silent reflux? Is this truly pathologic acid reflux? And the short answer is, if you truly have pathologic acid reflux, even with a small hiatal hernia, absolutely, this is a great procedure.
So speaking of the hiatal hernia, can you kind of talk about the concomitant or the Tif procedure versus just the regular straight Tif and the recovery?
Yes. So the vast majority of the procedures that I do are in conjunction with the hiatal hernia. And that's because I believe that most of the symptoms that somebody with bad reflux has are directly related to the hiatal hernia. So even in somebody with a small hiatal hernia, I usually repair the hiatal hernia. And I'll do that either laparoscopically or in some cases with a robot. Typically my revision procedures I'll do with a robot. But almost always my TIF patients are going to get a hiatal hernia repair at the same time. While they're still asleep, after we repair the hiatal hernia, we do the TIF part of the procedure. The recovery is actually very similar. I give my patients the option of spending the night in the hospital. Most of them do choose to spend the night. They feel a whole lot better the next morning. They go home right after breakfast. So it's less than 24 hours in the hospital. In some cases, patients do wake up that afternoon and feel fine and do well enough that they can go home the same day. But the recovery thereon is going to be very similar. By the way, there are a few patients that don't need a hiatal hernia repair. Those are few and far between, but there are some that their hernia is really small enough, or in some cases, for whatever reason, they choose not to have the hiatal hernia repair. As long as we can get the GE junction down where it needs to be, we don't necessarily have to do a hiatal hernia repair. So for those patients, the diet is going to be the same. The diet is going to be 2 weeks of liquids and then soft foods as tolerated after that for a week or two, and then slowly advance your diet. And we talk about how to progress the diet, and I'll typically describe it as a ladder, and the steps on the ladder are consistencies of food and that sort of thing. So I have 2 pages of instructions of exactly how to handle this, and we talk about it several times before surgery, right after surgery, and before they go home. The only difference between the two as far as recovery outside of that is going to be their lifting restrictions. If we do an actual surgical procedure, laparoscopic or robotic hiatal hernia repair, 6 weeks of no heavy lifting. If we just do the TIF only procedure, then we do 2 weeks of taking it easy, and then activity is tolerated after that.
So that goes into a question I've got Courtney asking, how can I care for someone who is recovering from TIF? What are their limitations? Sure.
Hopefully there's not a whole lot of care to be involved with. I request that my patients get up out of bed as soon as they're awake after surgery. First thing we want them doing is getting up and circulating the blood. That's how I refer to it. We got to keep the blood circulating, so get moving on a regular basis. Don't overdo it, but we want you up and moving. You ought to be able to get around the house very easily on day one. If you go home on the day of surgery, you ought to be able to get around the house, make it to the kitchen, make it to the bathroom. You can go up and down stairs. So there's really not a whole lot of help that they need. It's always nice to have somebody available, and if somebody can help you with meals and that sort of thing. The pain level is not significant. You're going to need pain medicine for 2, 3, 4, 5 days at the most. And so what I tell all of my patients is you can start driving again once you're off that pain medicine for 24 hours. So if you only need pain medicine for 2 days, 3 days later, you can start driving again. So pretty straightforward. Now, for somebody that maybe has young kids or has a job where that requires heavy lifting, that's where they may need some help. But beyond that, there's not a whole lot of help that's necessary.
So we have a question they said, I read shoulder pain can be experienced in the days after TIF. Can you explain why and how long it lasts?
Yeah, absolutely. So if you have a concomitant hiatal hernia repair, you're definitely going to have the shoulder pain. Even if you have just a straight TIF procedure, you can still have that shoulder pain. And the reason for that is we tend to feel what's known as referred pain in the shoulder and the neck. And so I try to make a point of telling all my patients that, hey, your incisions are going to hurt a little bit, but usually not that bad. You're going to feel some pressure in the chest where most of the work is done, but don't be surprised. You're going to have shoulder and neck pain that's referred pain from the diaphragm. That can happen immediately. It usually hangs around for a couple of days, but it slowly goes away over the course of the next 2, 3, 4 days.
We also got, are there any tips or tricks to prepare for the diagnostic testing, that you need?
There's really not a whole lot to do to prepare for it. The diagnostic testing typically is not that bad. So the way that I do it, so let me clarify that, because there are some people that still do the wire-based pH study. And so a catheter-based pH study is a catheter that goes down the nose. It's taped to your face, wrapped around your ear, and it's connected to the receiver, and you wear that for the next 24 hours. There's not a whole lot you can do to be prepared for that other than know what you're getting yourself into. The manometry is a catheter down the nose, but usually only for about 5-10 minutes. The hardest part of both of those procedures is putting the catheter down the nose, as you would expect. So number one, I rarely do the catheter-based pH study. We do the wireless-based, so that's not an issue. The manometry I now do with the patient asleep, so that's no longer an issue either. But short answer, there's really nothing you can do to prepare other than recognize and understand the procedure that you're going to go through and be mentally prepared for it.
Excellent. Well, I want to circle back, back on the TIF procedure. Can you, tell the audience how the TIF procedure differs, from the Nissen fundoplication, from kind of the gold standard fundoplication, and even the Links procedure, how it all differs?
Sure. So the whole concept of anti-reflux surgery is built around the idea of trying to create this valve, or in the case of the traditional fundoplications, such as the Nissen fundoplication, the Ppis, or even the Door fundoplication, what those are stomach wraps. And so what we're doing with those procedures are we're disconnecting the stomach from the spleen, wrapping it around the esophagus in some sort of fashion in order to create what looks like a valve on the inside of the stomach. And so you have to understand that what it looks like on the outside is not what it looks like on the inside. What we're trying to do, even though the work is being done outside, we're trying to create a valve on the inside of the stomach. And so the traditional fundoplication, specifically the Nissen and the Ppis fundoplication, tend to be a little bit hypertensive valves. So they tend to be supraphysiologic, meaning a better valve than what you need. And you would think that, hey, that's a good thing. If my valve is really weak, I want a really strong valve. Well, that's not necessarily the case, because you can run into some other problems with those. And so I very rarely do those traditional fundoplications because I don't want to put somebody in the situation of having what's known as gas bloat syndrome, which means you can't belch and you can't vomit. And that may be true for the rest of your life. The other thing that we know about those traditional fundoplications is that they tend to come undone with time. There are a lot of different studies out there that will tell you how long that they last. But the way that I think about it is think about what the stomach does. What is the stomach? What is its job? The stomach I will often describe as a big bag of muscle, and that's really what it is. And so it's a collection, it's a reservoir for food, but it's also designed for the stomach to mix acid and food. And so the stomach is constantly grinding and mixing that acid in an uncoordinated fashion. So that's what the big bag of muscle grinding food, that's what it does. So if we take the top half of that muscle, wrap it around the esophagus, and then suture it together and say, okay, you're a valve now, the stomach isn't really cooperating with that. It's going to continue to do what it's designed to do, which is attempt to grind and mix acid and food. So it makes sense that that's going to come apart. So the TIF procedure creates a very similar valve, but in a different manner. And this is what I like about the TIF, is what we're doing is we're taking the stomach and the esophagus that already live right next to each other, and we're just bringing it together a little bit tighter. And when we do that, you can visibly see the valve form on the inside of the stomach. So we're recreating the same type of valve, but we're not taking the stomach and wrapping it all the way around. We're taking tissue that is already apposed with an A, apposed, it's already together, and we're making it more together to create that valve. So that's the difference between those two. What the LINX procedure does is it's magnetic beads that go around the distal esophagus. And the concept is the magnetism of the beads keep it closed. So the resting state is it stays closed, and therefore helps to recreate that valve from that mechanism. We can get into the concepts of what the LES is if you want to talk more about that, and that'll make a little bit more sense. The LINX is designed, it was engineered to open and close at a certain pressure. That's really what magnets are. So they stay closed, but they will open at a certain pressure. And so as long as the stomach doesn't create enough pressure to overcome the ability of those beads to open, then it controls reflux, but it should be designed at a pressure so that we can swallow normally. So that's the concept, magnetic beads around the distal esophagus. The bypass works by a completely different mechanism. We don't need to necessarily talk about that unless somebody wants to.
Thank you for that explanation. There's a question, are there any swallowing difficulties with TIF? Have you?
So there's swallowing difficulties with everything that we do. So again, the other part of this equation is, especially for me, better than 90% of the TIF procedures that I do are in conjunction with a hilar hernia repair. And so when we do a hilar hernia repair, what I'm doing is I'm pulling the stomach back down. I'm not pulling it down, we're dissecting it out so that it comes down into the abdominal cavity easily, but then we're tightening up the muscle that lives around the esophagus. That muscle that lives around the esophagus, the esophageal curve, the hiatus, those muscles need to be able to squeeze on the distal esophagus. That's how it works. That's another component of the LES. So we are essentially turning your esophagus into a funnel. Now, that's not exactly true, but I explain to patients, this is how I want you to think about this. We're going to turn your esophagus into a funnel, so you need to be prepared that swallowing is going to be difficult initially. And until that scar tissue goes away, and until the swelling goes away, you're going to experience a little bit of difficulty swallowing. What I like about the TIF is, of all the procedures that are out there, that tends to cause less trouble swallowing. And in fact, when I first started doing the TIF procedure, that's how I sorted out which patients were going to get. If I was worried about their swallowing, then they would get the TIF procedure.
Thank you. You have a lot of fans out there today on Facebook. Dr. Michel Beth said, hi, Dr. Michel. You did my TIF a year ago, and it's been a blessing. So
wow, that's great. I'm glad you're doing well. Thank you, Beth.
Lots and lots of comments. Let's see, we also have another one. I think we've kind of touched on this, but what determines if I qualify for TIF? Yeah.
I do. Yeah, it's going to be based on the testing. That really is what it comes down to. Is that's the reason that I do the testing. Like I said, I want to figure out if this is somebody that's going to do well with surgery or not. And if the testing says you're going to do well, then you qualify. It really is as simple as that.
And we have another question. Does stress really produce a hormone that increases acid?
So yes, that is true. Now, the real question is, what does that look like clinically, and how do we prove that? That's a hard thing to do. We know that stress does increase gastric acid production, and if that excess acid in your stomach makes it into your esophagus, certainly then you can make the correlation that, hey, stress is causing me heartburn right now. So we do believe that is true. The extent to which it's true is really hard to say.
We have a question from Janice. She'd like to know, are there any contraindications to having this procedure?
Yes. So number one, I need to make sure that you're a surgical candidate. So somebody that has a bad heart or lungs or may not undergo surgery, that puts them in a whole different category. There are some relative contraindications with certain diseases, but the vast majority that tends not to be an issue. If you're a surgical candidate in general, you're probably a candidate for the TIF procedure.
Excellent. And then let's see if we have any more questions. We're kind of hitting that 30-minute, a little over 30 minutes. So I want to see Dr. Michel if we have any, kind of last words for our viewers, tonight. Anything you'd like to, say to them regarding TIF and the TIF procedure?
Definitely consider this. So if you're looking at surgical options for your reflux or treatment options in general, number one, you don't have to wait. You don't have to be on PPIs for 6 months or something crazy like that. I have a number of patients that come to me and have seen their gastroenterologist for months or years and have tried all sorts of different medications and they've increased the dosage. You don't have to wait for that. It is okay to look for a more aggressive treatment sooner. And in the end, I think that's going to be better for most patients. We talked a little bit earlier about how the disease progresses as we age. Not only does the disease progress, but your ability to recover from surgery decreases a little bit to a certain extent. The disease process may have an impact on how you recover and how you do from that surgery. So as a general rule, the sooner the better with something like this. So I don't think that patients should feel like that they have to wait and try every medication out there and double the dose and then add a Zantac or a Pepcid at night or something like that before you look at surgical options. If you have a hilar hernia, you're a candidate. If you already have some damage to the esophagus, you're a candidate. If you need more than once daily medication, for me, that's a sign you're a candidate. If medication stops working, you're a candidate. So pursue it earlier. You don't have to wait.
That is true. And we do have two last questions that came in. One is in regards to PPI. Should I be concerned with taking, PPIs for a long time or the prolonged use?
Yeah, good question. So the jury is out on that one. Several years ago, there was some bench data, meaning some lab studies that looked at PPIs and some of the problems that they may cause. We do know that they affect electrolytes, calcium, magnesium, that sort of thing. What we don't know is if that, as an example, that calcium alteration actually leads to hip fractures. We haven't seen that data. There was some data that says, hey, these medications may cause trouble with Alzheimer's and kidney disease and cardiac disease. Again, we haven't seen that data pan out. So I'm not sure that we really have that answer. The proponents for PPIs would point to the fact that millions and millions of people have been taking these medications for years, and we're not seeing people drop over left and right from Alzheimer's and kidney disease. But from my perspective, if we have a better way to do this, if we can get you off of those medications, then we don't need to worry about the answer to that question.
Great answer. And then Colleen's wondering how much pain can be expected after TIF only?
Yeah, good question. That won't hurt me at all. No, it's a little bit painful. Like I said, usually I do that in conjunction with a hilar hernia repair. So you're going to feel from the incisions. You're going to feel some pressure in the chest, and then, like we talked about earlier, shoulder and neck pain is pretty common. You'll experience that pain the day of surgery and that night, and that's really the worst of it. The very next day, it's a whole lot better. So less than 24 hours of having that pain, you'll still have a little bit of annoying kind of reminders of surgery for a little while after that, but actual pain is for the first 24 hours or so, and that's about it.
We have some more questions. Sheena would like to know, how long is the TIF procedure? How long will the TIF procedure take? And how would I know if I'm qualified? And I have a 9mm inner diameter hiatal hernia. Can that be repaired as well? So it's like a three-part question.
Yeah. So yes, how do you know you're a candidate? Again, it's the testing is going to answer that for us. How long does the procedure take? The TIF in and of itself can take as little as 15 minutes. Average is about 20 to 25 minutes for the actual TIF part of the procedure. There are some other considerations. We have to put you to sleep and get you in position and do the initial endoscopy and that sort of thing. But the actual TIF procedure, about 20 minutes, give or take. If we do it in conjunction with a hilar hernia repair, my hilar hernia repairs take anywhere from 45 minutes to an hour in general. If it's a revision, it may take another 30 minutes or so. So the entire procedure, about an hour and a half as a general rule.
Well, this is a question from Janice. I have OSA and use a CPAP at night. Will I be able to continue CPAP use following the TIF procedure?
Yes, and you should. In fact, you should use your CPAP for at least 2 weeks prior to surgery and continue to use it immediately after surgery, yes.
And Patrick, how long have you seen the TIF procedure last? Is this a long-term procedure? I had mine done yesterday and recovering.
Okay, good. Yeah, congratulations. Good for you. I hope it lasts for the rest of your life, and it should. Now, the data that's out there is, I think we're seeing close to 15-year data. So patients that are 15 years out from their TIF are still doing well. But as far as medical data, the way that we do data in medicine, we need decades of data before we can answer those questions. So hopefully what we're going to see is lifelong control. But we don't have that yet. Now, I started doing TIF about, I want to say 5 years ago, give or take, and I have a number of patients that are still doing very well 5 years out. One of the advantages of the TIF, one of the things that I like about the TIF is if that valve comes undone just a little bit, just enough to cause symptoms, it's actually very easy to go back down because it's an endoscopic procedure and sort of tighten up that valve. That's really not true with any other procedure out there. The TIF is the only procedure that we can kind of go back and tweak it a little bit if we need to.
Excellent. And Patrick, we hope you're recovering well from your procedure yesterday. So it looks like, we're coming to the end of the program, and we just want to thank you, Dr. Michel, again for joining us. How can our viewers find you and schedule an appointment if they are in the Summerville, South Carolina, Charleston area?
Sure. Just call the office. I think we have a graphic with the contact information. Yeah. So feel free to call the office. There is a website. I think the graphic shows that website. But just call us and make an appointment. You don't need a referral. We'll fit you in. If you're already seeing a gastroenterologist, by all means, continue to see the gastroenterologist and ask them for a referral if you prefer to go that route. But you don't necessarily need to do that. You come directly to us, call us, make an appointment, and we'll get you in as quickly as we can.
Fabulous. Thank you so much for joining us. Viewers, if you're in the Summerville, South Carolina, Charleston area, Dr. Michel is located there. His practice is Coastal Carolina Bariatric and Surgical Center, located in Summerville, South Carolina. If you're located outside the South Carolina area, please use our physician locator on gerdhelp.com. It'll help you find a TIF trained physician in your area. Again, we appreciate you joining us, Dr. Michel, and we will see you all next week. Have a wonderful evening.
All right. Thank you, Karen. Appreciate it.